Hi, Rachel. Thank you so much for being here today. How are you?
I'm good. How are you?
I'm all right. I think we both shared off the record that we were having a bit of a hectic day, so we're going to try to make this sound as educational as possible, despite the chaos. I wanted to start by asking you to introduce yourself to the listeners, and especially to maybe mention how your life as a mom may have influenced your practice as a physiotherapist or physical therapist, you say in the US.
Yeah, my name is Rachel. I'm a physical therapist. I've been practicing PT now for 10 years. I started in the sports medicine space, so more orthopedic. Really didn't think I had any interest in pelvic health. And then I think, like a lot of us have experienced, had a baby and was sorely disappointed by the experience of trying to stay in fitness as someone who was pregnant. And so that was an incredibly frustrating 10 months of how am I supposed to exercise? The advice, as you know, 10 years ago was completely different than it is today. And so the advice I was given, now is very outdated. But even at the time, I remember thinking, this can't be right. This just something feels wrong. It didn't feel natural to stop doing a lot of the things that I was doing. And so I feel like I lost a ton of fitness, got very frustrated. And then my postpartum experience was very similar in that the advice was just horrific. I mean, it was nothing for 6 weeks, then everything at the strike of midnight at 5 weeks and 6 days postpartum, and feeling very frustrated by that as well, doing a lot of things I shouldn't have been doing because there was no one to kind of like save me from myself at that time. And so was very, very frustrated by the experience as a whole. Loved, the fact that it brought my first into our lives, obviously. And I'm so thankful for a healthy pregnancy, but just wanted better for myself and for other people. And so once I went through that experience, really dove into the pre-postnatal world for a while, spent some time there getting more like certifications, learning more about the pelvic floor. Then what started happening was I started ending up more and more with athlete moms. So a lot of moms who were very active and wanted to run and wanted to jump and wanted to lift. And the research started changing of we can do all those things in pregnancy. And how do I do those things without increasing symptoms or increasing pelvic floor dysfunction? And how do I get back to them postpartum as quickly as possible while also being safe? And making sure I set myself up for long term success. And then,
What do you like to practice? What did
in
you want
terms
to
of,
do? Yeah, in terms of sports, why
yeah,
did you end up in these circles? What were you trying to practice but weren't sure and wanted to explore?
I played soccer my entire life. And so, again, it's a contact sport. So there was a lot of like hesitancy for that, which I understand. It's unpredictable. You can't expect to be hit or tackled or whatever during pregnancy or postpartum. But then again, postpartum, it was very much like, oh, you had your baby, so you can do whatever you want now. And that's not reality either. And so I, went back to playing adult league soccer. I mean, it wasn't serious soccer, but it was soccer with friends, and it was contact. It was co-ed, so I was playing with a bunch of guys, and would have symptoms during sport that were problematic. And so I, experienced a lot of frustration on that end. Now my kind of sport of choice is running. So I run marathons, I run distance, and there's so much interesting information coming out about distance running. And that's, again, a lot of my population. I think just because I do it, it attracts, clients who want someone who has been through kind of what they've been through. So worked with a lot of pre-postnatal athletes for a while, and then now get more and more athletes who do not have babies, whether men or women, and are experiencing pelvic floor dysfunction because we know that athletes are more likely to experience pelvic floor dysfunction regardless of if they've had kids or not.
Can you
So,
explain? I know why, but I would love for the listeners to hear why that is. Like, because I think that's the issue with old school doctors is they're like, oh, you're getting more symptoms, or you're getting more injuries when you, yeah, but being sedentary long term is not great. So, can you explain why we go through more symptoms as amateur athletes?
absolutely. The reality is that the way the pelvic floor works in our bodies, that's different, obviously, from like other mammals. So, other mammals don't have that downward pressure on the pelvic floor because they walk on all fours. we walk on two legs. And so the pelvic floor is at the base there. And so when we bound, jump, lift, all of those things increase downward pressure onto the pelvic floor. And so, for example, with running, every step you take, there is that downward force on the pelvic floor. If you run long distance, that happens over and over and over and over again. If I lift heavy, that increased pressure at my core puts downward force on the pelvic floor. And so that's a different demand. It's a different increase in pressure. The reality is, as athletes, we put different demands on our muscles. So like you said, there's not benefit to being sedentary. I don't want to tell patients or clients to be sedentary to combat the downward pressure on the pelvic floor. Our goal should be that we create a more resilient pelvic floor that can handle the load demands of the sport of choice, whether it is Olympic lifting or running or jumping or gymnastics,
At
and
at
matching that.
the same time, we want to do this in a way that is sustainable. I feel like what I like about your work and where I resonate with your work is I feel like we're in between. We don't have a specific agenda. All we want is for people to do what they want to do for the rest of their lives, but we are a bit cautious at certain, points through the
Absolutely.
perinatal journey to make sure that that is possible long term, right? So
100%. And I think
we either have very conservative doctors or very like go do whatever you want 2 days after giving birth researchers. I feel
And I
like
understand the thought of wanting to empower women to go do things that they want to do. Because trust me, I would have loved for someone, at 2, 3, 4 weeks postpartum to say, oh, everything's cleared. And to be fair, at 2, 3, 4 weeks postpartum, I did not have any symptoms. I had had a grade 2 tear, so I did have a tear, but I was feeling so much better. I kind of turned a corner. We were settling in at home, and I was dying to go on a
yeah,
run,
let me
right? You're like,
go.
heck yeah, this baby is out. Like, my body is mine again. I cannot wait to go experience those endorphins. Because when I was pregnant, the 140 beats per minute thing was still a thing. So I never went to run because it would have gotten my heart rate above 140. And so I'm dying to go on a run. And so I do. And that's when a lot of my symptoms started. And so again, I using symptoms as a guide for athletes who are used to kind of compartmentalizing pain or discomfort or dysfunction, it just doesn't always work. And so we know things about healing, right? Anatomical healing, physiological healing. And again, I understand the concept of like we want women to return to sport and return to activity as quickly as possible. I also think that in some way, to some extent, athletes kind of need to be protected from themselves a little bit. And we don't question that for any other body part, right? If someone comes with a knee pain or shoulder pain, and I think, man, you really need to sit out from your sport for a little bit, I'm honest with them about that. As much as I'd love to just clear everybody and get them back out there, I think we have to be honest about what your body just went through. And the pelvic floor can be challenging because you can't see it. And so sometimes you do need someone who specializes in it, who has background in it, to say, I know you feel good. I know you're itching to go on a run. I know you can do these bullet pointed tasks because you see them all the time, right? Like, oh, if you can do these 10 things, you're good to go on a run. But the 10 things are like, oh, you can stand on one leg for 10 seconds. Like, what does that have to do with the amount of force going through your pelvic floor on a run, right? That doesn't, to me, that doesn't correlate. So I understand you checked these boxes and that makes you want to go run. Are those things
Especially as an
helpful?
athlete, I feel like if you're an athlete, you were probably doing this at the end of pregnancy anyway.
Correct.
You were probably able to do this. Like if your birth wasn't not challenging, you were probably able to do this 2 days postpartum. Does not mean you're ready to put that kind of pressure on your pelvic floor. That is to be demonstrated, right?
Well, and I think too, like part of what I think you and I have connected on as well is that like the pelvic floor itself is not just muscle. So like, yes, muscle matters and muscle healing matters, but like, let's say you had no tearing at all. Great. Wonderful. That's amazing. Your connective tissue still went through a giant transformative process where we know the pelvic floor and the connective tissue stretches a crazy amount more than any other muscle in our body for any other experience that we go through. And so we cannot expect, like, I can check your muscle at 2 weeks postpartum and you may have pretty good muscle strength. Now, is that common? No, but that doesn't mean there's not an athlete here and there who doesn't have good control, doesn't have good strength endurance at 2 weeks postpartum. That's absolutely possible. Does that mean your connective tissue has healed to the point where we're ready to go pound on it, for miles and miles? It doesn't. And so as much as I understand the concept and thought of we are limiting women by saying, hey, don't do this until this time, there is some benefit of like, hey, clinically, if I see 100 athletes, this is kind of the timeline that I generally see that I think people are able to get back without symptoms. Because I could clear you at 2, 3 weeks postpartum because in the name of empowering women, right? And then you go on a run and you're like, why didn't you tell me that I was going to have all these symptoms after?
Exactly. There's a
And
responsibility
and you
that
can check all the boxes. You can check them all, right? I can do an internal exam if we want to do an internal exam. I can do an external exam. I can watch you hop on one leg for 10 seconds. That does not mean you can go run 3 miles without symptoms. And somebody needs to tell you that. So, like the timelines that we put out there are based on what I've seen clinically and what I think lines up with not having symptoms afterwards as well. So, not just will you be symptomatic on your run, but when you come back to see me, in a couple weeks after your run, did you feel symptoms after? And so I think we need to find the line of like, okay, we want to empower women. We want to give them all these tools and all these opportunities to get back to the sports that they love. But we also want to be realistic about what your body just went through and the timelines that typically are required of healing for everyone, because there are some things we cannot speed up regardless of how good of an athlete you are. And I think that that's important to acknowledge in some way, shape, or form when we're having these discussions.
I love what you've just said. And I feel like there's this assumption in fresh research the past couple of years, I would say, that women don't care about symptoms and it's all about their mental health. And again, if you really need to go for this run, I want you to go for the run, if your mental health depends on it. But if your question, usually when women ask us, am I ready to do this? They mean, am I going to have symptoms? Is that going to delay my recovery? Am I going to be able to do what I want for the rest of my life if I go on this run today? It's not, oh, it doesn't matter that you're, that you're not symptom free or that you have no symptoms now and that they could come later. Maybe it does matter to women. I feel like it's being kind of disconnected. Do you feel like it's being disconnected from what most women want? Most women are big girls. They can hear that they need to wait it out a little bit longer with
And
the
I
right.
think for some athletes, it can almost be validating to hear that they need to wait a little bit longer because, of course, we want to rush back up to sport. And I want you back as quickly as possible. But do I want an athlete who's 3 months postpartum, who felt great up till 3 months, we went back to sport. Now we're starting to notice symptoms. And now we're losing time from sport because we created symptoms from returning too early? Or would I rather have an athlete who at 3 months, followed a really smart recovery plan? And because of that, as soon as they're back into sport, can really launch and go upward, right? So we can see that upward trajectory versus someone who goes back too early. And the reality is that fourth trimester and that really even that first year to 2 years postpartum, there is so much change going on in your body. And so much of you is just kind of getting back on your feet, relearning how your core, your pelvic floor, how your hips work, like reconnecting to all of that. Yes, that involves heavy lifting and power work. And like, it's not just Kegels on a table. So there's so many things we could do. And so like, if I have a mom who comes in, let's say 4 weeks postpartum and says, Rachel, I need to go on a run. My mental health is absolute garbage right now. Okay, well, one, we could go on a run, right? Could we talk about intervals? Could we talk about biking instead? Could we talk about hill jogging? Because I know that that puts your pelvic floor in a more advantageous position. So having those discussions of like, okay, yes, I want your mental health because trust me, those first few weeks, those first few months, that first few years are hard postpartum when you don't feel like yourself. I want to give you that, but I also don't want your mental health to suffer in 6 months because what the heck are these symptoms that Rachel kind of never talked to me about could be potential from easing back in too early, right? And so it's a fine line of do I want you to be the best athlete possible in this moment, or would I rather you be the best athlete possible 6 months from now?
Yes.
Just like we do for every other recovery process. And sometimes that requires me to be the quote bad guy and say like, hey, listen, like you can go do this. I can't stop you, but I do have to disclaimer. I think it's a little early. If we give it another 2 weeks and really work on these things, I think that we could make a really big difference in the potential of these symptoms to show up down the line. Because just because they don't show up after that first run doesn't mean they won't show up after the 10th. And it is my job clinically to be honest with you about where I think we are, what I think we need to focus on, and how to ease back into running in a way that is safe and effective so that 6 months from now, you don't need me, right? Not 6 months from now, well, I guess I got to go back to pelvic PT because I have these symptoms that I may not have had we been a little bit smarter in the beginning of the process. And so it's a fine line of I want you to do all the things, but also we have to respect physiologic healing. And to me, just checking the muscles doesn't always check the boxes. I have athletes who have great strength coordination, endurance, and it doesn't always translate, especially postpartum.
That's true empowerment, actually.
Mm-hmm.
It's just not one telling people what they want to hear, just using your skills and what you know and your clinical expertise to say, I think that at this point, this would be more beneficial for you long term. So, with that in mind, what signs tell you that a woman is truly ready to return to impact, since it's not purely strength and coordination? What do you look for when people want to start impact, like running, maybe tennis? Because tennis puts a lot of pressure on the lineal. That paddle is big here at the minute. I
Mm-hmm.
don't know about the US, but there's a lot of rotation involved. So there's pressure. Volleyball, there's a ton of pressure going downwards. So yeah, what signs tell you a woman is ready?
One, I want to obviously check in on symptoms, and this is again where it gets very nuanced and not quite as black and white as I think we probably would love for it to be. But just, if you're listening to this and you're kind of like, well, what are some things that I could check off the list? I think, having a really good foundation of, can I contract? Can I relax? Do I know what those things feel like? Do I feel good in my day today? Like if I go on a 30-minute walk and I have symptoms, a 30-minute jog is probably not going to feel good, right? So I think we're always trying to look at a mismatch between what the pelvic floor is ready for and what it's not. So, like, if I'm doing an activity that creates too much pressure that I'm not ready to handle, that is where I will see symptoms. So, if we boil it down to the problem, it's a mismatch in what I'm doing and what my muscles are ready for. And so if I do, it's the same way in the weight room, right? If I try to deadlift, I don't know, 150 pounds and my back starts hurting, okay, there was a mismatch. I wasn't ready for that. So let me drop that weight. Let me, work on form. Let me do things and then I'll come back to that down the road. So I look for asymptomatic walking, so longer bouts of walking. Again, the reality of our bodies, the way the pelvic floor is structured in our bodies, I look at the duration, especially when we're talking about running, because one of the concepts that I love that the sports medicine and pelvic floor textbook has really brought up is talking about the concept of creep in these passive tissues. So maybe my muscles can contract and relax over and over and over, and they've gotten really good at that. But there are also passive structures in the pelvic floor that as I stay on my feet for longer and longer, they start to create a little bit of dysfunction there, and that the collagen fibers start to get dysfunctional, right? So they
Can I
change.
just stop you right there?
Yeah.
This is why, for mums who are listening, this is why after your second pregnancy, walking for longer duration felt awkward. It feels weird.
Mhm.
It's because of the collagen fibers, because these tissues have been stretched and have already supported a lot of weight repeatedly. And that's why the second, I don't know about you, but I experienced that big time. My second pregnancy, going for walks, and I wasn't that heavy, felt like I was telling my doctor, "Where is that?" He was like,
Yeah.
"It's not your first time."
Correct. And so a lot
Sorry.
of times, like early postpartum, I would rather, if you want to get up and walk, I love that. I want that for you. I would rather you do it in short bouts. So instead of a 30-minute walk, maybe we do 3 10-minute walks throughout the day. Like let's go out for 10 minutes in the morning, 10 at lunch, 10 at night. You're still getting the same amount of steps in, you're still getting the same amount of exercise, but it gives your muscles a break to where they don't have that downward pressure on them for extended periods of time. Because the pressure that your pelvic floor is feeling at the 29-minute mark is very different than the pressure it feels at the 9-minute mark, where you give it a break and then you come back later and you're kind of fresh and can recover a little bit between walks. So I'm not anti-walking, but one of the things that I'm looking for if I'm talking about return to running is that I want to know that those collagen fibers can handle a decent chunk of time under load without symptoms. And so if we can't walk 30 minutes asymptomatic, then I'm going to be a little bit more reserved in integrating running. And then when I integrate.
Would there be heaviness? Would heaviness be one of the symptoms? Because I feel like that's something. Because women hear symptoms and think, "Oh yeah, no, of course I don't leak." But if you feel heavy,
heavy pressure, like sitting on a ball when you come back. Those things are things to watch out for. I do have clients kind of like keep I say a journal, but a note in their phone of like, how long does that heaviness last, right? If you come home and you prop your feet up and it goes away fairly quickly, okay, cool. That's great. It's the same way when we go to the gym and you get a little sore sometimes and then it goes away and your body gets used to it. That's probably fine. If the heaviness and pressure lasts for more than like 24 hours, then we probably overdid it. And those collagen fibers need time to repair themselves before we go ask more of them again. And so I want to see a longer duration walk and want to feel comfortable with that. Want to make sure that we're fairly asymptomatic for those longer duration efforts. When I am easing people back into running, I'm using inclines a lot because that incline leans us forward. It puts the rib cage over the pelvis. And so it puts us in such a good position to manage pressure. Even long-term postpartum, like a lot of times if you have leaking or again, heaviness, pressure, pelvic pain, tailbone pain, it comes with downhill running. And it's because when we downhill run, we have a lot of force we got to absorb in that downhill. And your knees are jarred, your feet are jarred. You have to really learn to like soften and lengthen in those downhill runs. So using uphill runs to our advantage. So maybe let's jog uphill, find a hill in your neighborhood, jog up the hill, and then turn around and walk back down. Do we have symptoms? Right? That incline will just take a little bit of the force off so that you don't have to absorb as much force. Your body can kind of learn and ease into that slowly. So using hills to our advantage and then making sure that when you do start running, we do it in intervals for that exact same reason. I don't go on a 30-minute run for my first run. I might do a 1 minute walk, two minute jog, 1 minute walk, 2 minute jog, where I'm kind of on, off. Because again, in those little 1 minute walks, I'm getting a lot of passive, blood flow. I'm getting all that kind of recovery in that 1 little minute. Now, is it full recovery? No, that's not the purpose. But I'm getting a lot of recovery, giving my collagen fibers, my muscles, a quick little breather. Okay, get it together. And then we're going to try this again. And then we can increase that way. Now, again, what we were talking about earlier, the quote downside of that is it's slow. It's a process. I would love to just tell you to go on a 30-minute jog, but if that's the first run that you do is a 30-minute jog, it's not a super high impact activity in terms of like, okay, we're not adding a bunch of weight to you, but obviously your body interprets running as a high impact activity and you're doing it over and over and over for that extended period of time. So it's a very specific input that we just have to be smart about. And so it's not just, hey, you're cleared to run, right? Like I don't say at 8 weeks, you're cleared to run, go do whatever you want. There's still a process. Can we try some incline running first? There's tons of ways to get cardiovascular health that are still advantageous to pelvic floor healing and making sure that we're making those right steps in the right direction, as opposed to just, again, clearing you for all get out, which is probably what you would love to hear. And I hear that. No one wants to hear, hey, it's going to take 12 more weeks for us to kind of ease into this. It doesn't mean you can't play your sport. It doesn't mean that you can't do things you love. It just means we need to be smart. And I think
You've been
that's
through a big event. I feel it resonates with me a lot because I don't coach runners, but I see it as a studio owner because as a studio owner, you've got editorial content. The culture is yours to create. So that's what I love about it. Um, but it took me, when I was working with studios, it was so hard for me to try and get them to not accept just anyone at 6 weeks because obviously they want the cash. And I get that, and also they're not specialists, and the doctor said so. But I was like, it makes no sense for me to have someone who can do a lot of flexion without downward pressure, with controlled intra-abdominal pressure, and with non-distended tissues, you know, and then someone who's just fresh, whose connective aponeurosis is still healing and still coming back, and like you said, collagen fibers and all. And it's just such a hard message to convey. It puts you in that bad cop position, but frankly, I don't care because my reputation is, that if you're with me long term, you're going to rock it, even medium term. So you're going to be the best in class. You're going to have the strongest abs. Why would you want to damage your abs now just for the sake of doing this on the reformer? I feel like I'm experiencing that, and you just have to feel strongly enough about your expertise and about what you know of the physiology of the postpartum body to go ahead and do that. But even research sometimes it does not support this, the process, the idea of a process. So I find that sometimes a bit frustrating. Maybe we should run something. We should
Well, I
run.
always tell people like the reality is, to me, what I've seen clinically, and I have published research. Now, it's not a systematic review.
Amazing.
It's, just I have published research. I have three published studies. One's on elbow, two are on pelvic health, and um, it's a process, right? But like all of the things that we see in the research tend to be things that we've already been kind of doing and experiencing. So athletes have already been noticing them. Clinicians have already been doing them. Trainers, coaches, any performance staff has been kind of like implementing these things, not totally understanding why they work. And then the research says, okay, let's figure out why, right? So we can back this up and we can defend it. And it's so important. But those things have to go hand in hand. And then you can have a research study that shows, I mean, I joke about this, but I tell clients all the time, I could do a research study that shows if I dedicate 400 minutes per week to exercise and I do this and I do that and I wake up and I blink 18 times before I have 4 ounces of water and that improves my longevity by 20 years. That's great. Is it something I can implement? No, doesn't matter, right? So here's this perfect research study that tells me I can do all of these things will be my outcomes, but I can't do it. It doesn't work for me. So then what? Right? So then what do we do next? And so there has to be someone who can take that research. Hey, this research is great. It didn't work for this person. What do I do now? Right? And a lot of the research that does come out eventually comes from those gaps and filling those gaps. So we were talking about the passive tissue, and I posted recently about we use overcoming isometrics for a lot of tendon and fascial collagen health in other parts of the body, the shoulders, the back,
Yes.
the hips. We have not been using that in pelvic floor health because pelvic floor health has been very focused on the muscles, which is great and important and necessary. But I have started using overcoming isometrics for the more passive structures to try and reorganize those collagen fibers and make them more resilient. And clinically, we see great results. So these are clients who come in, they're still having symptoms despite doing pelvic PT in the past. If we do an internal exam, they're very strong, they're very coordinated, they're doing all the things, everything, quote, looks right. Why am I still having symptoms? We implement these overcoming isometrics, and suddenly in a couple weeks, things are really improving and making a difference. But when I sit that person down in my chair afterwards and I say, okay, here's the deal. I don't have a research study that says why that works. They don't care. They're
Of
better. You know
course.
what I mean? Like do we need a research study? Sure. Do you want to do a research study on overcoming? I'd love to, right? Like, let's do it. But if that is what's working, and I've seen it work so many times now, because I started doing that probably like 3 years ago, trying to implement more of those passive tissue kind of approaches in addition to the regular active tissue approaches. And it is such a good fix from what I've seen. It makes such a difference for people. And so when I sit someone down and I say, listen, I've got 10 years of clinical experience. I work with athletes all the time. I work with people who are in your exact situation. I don't have a study showing you that this is going to work or why it works. I don't have that available to you, but I can tell you I've seen it work over and over and over again.
That's worth trying.
And maybe 5 years from now, I'll have a study that I can give you and say, hey, this is why we do what we do. But then in the meantime, did I lose 5 years of outcomes for athletes who I was just not doing something because I didn't have a study to back it up?
Yeah.
So finding that balance of what is safe, because that's always our ultimate goal is like, okay, we have to be safe, right? Don't go do things that are not written in the research that are unsafe for a client. But if I know how passive tissue works in other parts of the body, and I know a lot about the pelvic floor, could I like start to just bridge those gaps? Because that's what everything pelvic health has been is like, wait a second, these are muscles just like everywhere in the body. We should train them the same way. That's picked up. We've made progress there. So now the passive stuff comes. Can we implement that more and more? Can we see that carry over and understanding that research is amazing, clinical expertise is amazing. They both have a place in patient or evidence-based care because evidence-based care is not just research and it's not just clinical outcomes, right? It's clinical outcomes, it's patient preferences. So if a patient comes in and they say, I want ultrasound, and I sit there and I bark back and I say, ultrasound has no research, and they say, but that's what I want. Will that work for them? It probably will because
Yes.
that's what they want. That is their preference. So I can sit here all day long and say, well, the research isn't good on ultrasound. And they say, well, I want it. Guess what? When I do ultrasound, they might get better because patient preferences matter. So if their preferences your outcomes that you see clinically and the best available evidence. When you combine all of those three
Mm.
things, that's where the magic happens. But
Yeah,
that
and I love
takes
to, I feel like
experience.
logic is underrated, like what you were saying you were applying. Like if this, so if, let's say if I'm working on, like someone is telling me, no, no, you should start with curl ups before activation and this doesn't work. And, but then eventually you understand how tendons work and what kind of pressure you need to, what kind of tension you need to apply. So it's not deleterious, but there are adaptations. So you eventually can lead your patient or client to the outcome, which is I want to go to a normal class, or I want to chase my toddler without symptoms. I think you're beating anything. Any, like you said, clients don't care. They don't need to know. And like you said, reading and or creating research is great, but at the end of the day, outcomes and logic.
Mhm.
It makes
And
sense.
logic takes time too. That's why, like, when
Yes.
you're finding a clinician or a trainer, like, it does obviously help to have someone who has been through these things, because a lot of what I'm implementing on a day-to-day basis in the clinic is stuff that I'm kind of like, we're going to try this. We're just going to
Mm.
try it, because based on what you told me, based on what I know about the rest of the body, I can't guarantee it's going to work, but I feel like it might, and let's give it a shot. So same thing with pelvic weights, right? So like for the adductors, for anything that's tight, for so long we said, oh, we're not going to strengthen it because it's tight and that's not good, and we need to stretch and only stretch. And then we learned, wait, when we strengthen those tight muscles, we see better results long term. So we need to stop the whole don't strengthen the adductors. We started strengthening adductors, and then everyone had better mobility in their adductors. For the pelvic floor, when I first started in pelvic health, we did not prescribe pelvic weights for patients who had overactivity. Now I do it all the time because we realize that, for example, the adductors, when they're tight, they like strength, right? They like to focus on those things. Why would the pelvic floor muscles be different? So now, instead of avoiding pelvic floor weights, can I implement them in a way that makes sense for the client? And again, as far as I know, there's not a ton of research on that, but like, we know clinically it works incredibly well. So you have these clients who are like, well, I was always told I had an overactive pelvic floor, I shouldn't strengthen it. And I think actually there might be one study that's like popping into my head that kind of showed that clients who had quote overactive pelvic floors did better with strength and down training than the just down training group. So if I stick you in child's pose and breath work and I keep you here forever and ever and ever
You're never going to
until
relax.
we relax, we're not going to get anywhere. We're going
I
to
it's so
plateau.
interesting for me. It was overactive and spasming and very tough first birth. Plus, I was abused as a child, so there's a lot of trauma there and tension and inability to relax, right? But what worked really well for me was when I created this exercise called the blueberry, with a proper activation of the levator and but in deep squat. So it
Mhm.
was lengthened enough that I could tolerate that lift because they were in rehab back then. They would make me lie down on my back, contract. I would get horrible spasms, be in tears, and hear, "Oh, it was a tough birth, wasn't it? Come on, I'm having a
Yeah,
spasm. Of course, it's
100%.
painful." And then I had to get that knowledge and to think, okay, let me put myself in a lengthened position. Let me see how that feels and try it. If it spasms, I won't do it again. And that's the first time I was able to do contractions because I could then fully release. So, like you said, it's not black or white. It's not, oh, someone has an overactive or hyperactive pelvic floor, overactive pelvic floor, sorry, and they should never strengthen, of course, because they're getting weaker because of that tightness. So we need that to get a
And
relaxation response. You need a contraction sometimes, right?
that strength gives your body permission to soften, right? So I don't have the strength. It's going to try to create that for me by going into a spasm. And so when I teach the muscle how to be strong during certain ranges, like you said, in the deep squat, at the top of the squat,
Dosage as well. Dosage. Why
correct,
ask for
dosage.
100% contraction? Ask
There's
for
a reason
less.
that we call it exercise prescription, is because how much I prescribe to you matters. And so I might tell you 8 reps, 3 rounds, right? That doesn't mean you do 24 straight. It means you do what's challenging for 8, you take a break, and then you do it repeatedly, because tissues respond to specificity. I think you also touched on this that I want to like kind of hammer home for everyone. Pain, and especially pelvic pain, is multifactorial. There are multiple things that go into it. So again, just pelvic floor muscle training alone is a wonderful tool, but it is one of many tools. Passive training matters. Going to therapy matters. Being able to talk about these things matters. Taking the taboo away matters. Having a provider who you can explain, hey, this hurts. Can I talk to you about that without feeling judged matters. So, like, there's all these kind of different things we have to understand as providers and again, as patients. So, part of the goal as a clinician is also to teach patients how to advocate for themselves. And
Yeah.
when they don't understand the pelvic floor, why it works, how it works, what it's supposed to do and not do, how do you go to the gynecologist and explain, what you're experiencing when you don't even know how to explain it in the first place? And then how do you know when I explain to this gynecologist, hey, this is what's going on? Is this someone who's listening and hearing me, right? Or is this someone who seems to like not understand it and maybe I need to find someone new? So part of what we have to do is not just treat people, but teach them to advocate. Because the reality is, at least for our generation, this is something that is still growing so fast. And so, as much as I would love to say that next week it will be standard of care that we talk about these things, it won't. And so, in these cases, I have to teach clients, hey, next time you go in, you need to ask about this. You need to kind of bring this up because
Yeah.
this may not be my scope of practice, but this is something that would really help us on the muscle side. So, like hormones are a big one right now, like all the tendon health issues that we see with estrogen decline. I can teach you all the tendon work in the world. If it is an estrogen problem, we're only going to get so far. And so I don't prescribe estrogen, right? But I can explain to a client, hey, this matters. If you can go ask about this the next time that you go in, then what we do here clinically may really be helpful, right?
What's been your experience with laser? Because I found with some level, stage two prolapses, it's been helpful. I can't really explain it. It's not my area of specialty. I'm a movement specialist, but yeah, what's been your experience? I'm curious.
With estrogen and prolapse.
No, laser.
Oh, later.
Yeah,
It depends. I think it depends on the client. Again, prolapse is so multifactorial, again, in that it's not just a muscle problem. It's not just a passive tissue problem. We have such a long way to go in terms of fully understanding prolapse. I think it can be helpful for some people. I think it's one of those things that, again, it is a tool in the toolbox and it should be combined with other adjunct therapies as well,
modalities. Yeah,
including the muscle training. So, like, if I have someone who comes in with a grade 4 prolapse and wants to try conservative treatment, again, it is my job to explain that grade 4 typically does not respond to conservative treatment. Grade 1 through 3 does. I'm happy to work with you. We're not going to hurt anything. We can get stronger. If you choose to take the surgical route, then your outcomes will probably be better because you did this first anyways, right? But if I have clients who are like, I'd rather just go ahead and have the surgery and then come in, okay, I love that. Let's do some post-op care the same way we would for any other joint tissue, etc. I get frustrated when we do something like laser or, surgical care and we don't change what caused it, right? We're just putting a band-aid on it. And as wonderful as you may feel post-op, which I love, I want that for you. I don't want in 2 years for your symptoms to be right back where you were because we never fixed the root of the problem. And so if the root of the problem is stability or strength or mobility or length, I want to address that too.
yeah.
And I think that's where we have a really unique opportunity to bridge that gap for people so that your outcomes actually stick, right? And then you can go do all the things that you've held off on because of your symptoms without worrying that, hey, this is just going to come right back.
Hmm. Same with weight loss, I find, or even, taking meds when you're unwell. Sometimes if you're not doing the work, then there's only so far. I mean, can only take you so far, right? Whether that's for your mental health or that's for weight loss. I find that if you don't do everything around it and get to the root cause and do the work, like we say, it's hard to get lasting results. You might get short-term relief, but some of these problems are going to come. They're going to come back. They're going to
So I tell
come back.
clients all the time, like if I could take, a 60-minute training session and put it into a pill, there's no one on this planet who wouldn't take it daily, right? Like if I could take that and put it into a medication, we'd absolutely do that. And truthfully, with all the like peptide GLP-1, again, this is not my scope of practice, but just knowing what I know about the muscle groups, it is something that comes up in our practice a lot. I'm not even against that. If I feel like we're stuck and I see you doing the work and I know you're working with a nutritionist or a dietitian and I know that you're doing all of these things, and I just think there's things that we still don't understand about women's bodies and how it changes with menopause, perimenopause. And so if I know you're doing the work, let's go for it. Like if that's something that you want to try, I'm going to be right here with you. If it works, it works. If it doesn't, it doesn't. But that doesn't it's not a substitute, right? Like we have to do the training on top of that because I want you to have the muscle mass. I want you to have the bone density. It's not just the number on the scale that matters. Of course, we can see that come down with some of these like GLP-1s, and that's wonderful for people who need it and feel like they haven't seen that needle move despite doing the work. But it doesn't build muscle. It doesn't build bone density. And those things are, I say, like our hay in the barn for when we get older and we can't train anymore. I need to have those in reserve, knowing that we all face the gradual kind of decline that happens as we age, and we can slow that down as much as possible by having that big reserve. And so a lot of clients will ask me kind of my thoughts on that, and my thoughts tend to be like, listen, you're doing the work. If you're doing the work, I will support you in whatever you feel like you need. Go talk to your doctor. You guys figure out what works best. If that brings the number on the scale down, which helps your cardiovascular risk, which helps your fight your family history of a hemorrhagic stroke, then that's probably not a bad thing. But can we also make sure that we're just doing my side, which is the muscle and, musculoskeletal health, and making sure that we're doing that as well? Because again, right now we don't have a GLP-1 or a pill or a peptide is not a substitute for a 60-minute training session. And again, if I had two pills, you'd take both, right? But we don't have the exercise. We don't have training in a pill. We have to do that work. And so that has to come with what we're doing.
Maybe because we have curiosity instead. Maybe because that's the point of life, to figure out what works for you. And
Correct.
so
And
maybe,
what works for you may not work for someone else. So like
yeah,
I
but
see
that's
all the
what your
time,
symptoms are telling you. Like you can't
right,
sleep, or you can't run, or you can't. What does this mean? If you approach it with curiosity, of course you can get relief in the process with whatever pill. But the training is because you need to figure out your perfect prescription for the
correct.
next 10 years, right? Yeah.
Correct. And it's again the same thing with pelvic health training in general. Like I can write a program for person A, and maybe person A and person B both have the same exact symptoms, but the program that worked for person A didn't work for person B. And then what? Right? That's where clinical reasoning has to come in. And I don't expect an athlete to do that clinical reasoning for themselves. That's my job to say, like, okay, that didn't work for you the way that I thought it would. Why? And like we talked about earlier, pelvic symptoms and symptoms in general are typically a mismatch. Something's not lining up. What I'm asking my body to do, it's not quite capable of yet. Why? And that's where the
Yet,
solutions could be.
yet is very important. Like
Yeah,
not being trapped in the now is going to be the forever. You
correct.
have no idea what the next year will look like or what the next 10 years will look like. But if you are interested in the process, again, curiosity, then you will live so much better through these symptoms. And that's a hard message to people are so used to modern medicine selling this is the pill. It's almost a reprogramming of the way we've been raised. But yeah, I have one more question, and then I want to talk about your book.
Mhm.
So, if you could remove one message, I think I have an idea, but about postpartum recovery from the internet forever, what would it be?
Oh man, I probably could give
That's
you like a
tough.
list of
There's a few.
yeah, that's a great question because there's so many things out there that are just, I think, so harmful in those first phases. There's probably an answer that I have as a clinician, but then also an answer that I have like as someone who's been through that postpartum experience. I think having been through postpartum, um, the message I would want to remove is you're behind. We are inundated with too much information. And this girl's doing box jumps at 3 weeks, and this girl's doing that, and this person bounced back, and I'm supposed to look like that, but I don't. I've got spit up on me, and we didn't sleep last night. And like, if I could remove that comparison trap of the internet that happens, I needed that to be removed as an individual, not just a provider postpartum. Feeling behind, like we just said, it is such an individual process. And I think it's important to touch on because, again, I do have research out there that has timelines on it. My hope with that has always just been to provide what I see clinically, never to make someone feel like they are ahead or behind. I don't want you to look at that timeline and be like, look how far advanced I am. That's not the point. The point is that we need to work through these things. Here's a general idea so that you can kind of get a gauge. But if you have someone who like does can't come in and do rehab until 6 months postpartum, okay, that's fine. You're not behind, right? Like you said, every day is a process. Like every day is approaching it with curiosity and kind of like, this is where I'm at right now, giving myself grace for the things that I haven't been able to do because I was raising humans, because my child didn't sleep at night, because my kid had colic. Like, you are not behind. And I think that message needs to be just deleted, the bounce back approach, because to me, a bounce back implies something passive. It's a recoil, right? When I jump on the trampoline, it's going to put that force right back into me. The recovery in the postpartum process is anything but reflexive. It is active. It is something that takes a lot of focus and intention and time and grace. And the bounce back to me is just completely different than an active recovery process. So the bounce back, I just need that removed. That doesn't happen. Okay. It's
Like it
something
would
that
with
has.
any surgery, like I had nerve surgery 2 years ago. A nerve, if you don't force, and that I think that's why so many people who have Morton's neuroma resections find it unsuccessful, is because the part where you have to go to the physio and allow the physio to touch your nerve until it's desensitized is brutal. It's not passive, and like you said, it's not recoiling. And postpartum is very similar. There's nothing. It's active. It's an
Mhm.
active reconditioning of tissues and connections that have changed, and it takes effort, and there's no pill. We are
I think
underlying.
that flows into the idea of what I would remove as a provider, which is, again, that bounce back approach. Because as a provider, I want you to take postpartum just as seriously as you would take an ACL repair or a knee replacement. You are dedicated to that recovery process and making sure that you are at your healthiest version of yourself when you decide to go back to all the activities you love. But as new moms, especially, we table a lot of that. I don't have time. And I want to just get back to it. And so I'm going to skip that, right? You would never do that after a hip replacement, after a knee replacement, after an ACL repair, after a rotator cuff repair. You would never just be like, I'm going to skip the recovery process.
Also,
I'll just
your
get
your husband wouldn't do that after a sinus infection. You
back.
know what I
Yeah.
mean?
Yeah. Yeah. I love my husband to the moon and back, but man, the man
like,
cold is.
I just find it so interesting how I love that these days, this new generation, because I'm starting to train people who are younger than me, right? And the husbands are coming with the kids at the studio so the woman can have
Mhm.
that hour. And I'm like, we've gone a long way. We're not quite there yet, but if husband are like, yeah, I told you I told her she needs to do this. And
I
again,
have women all the time in this office who, like, when we talk about, like, how long is this going to take? What's this going to look like? We're getting scheduled. And they're like, oh, no, my husband can watch them during. Oh, no, my husband, he would want me to come in more frequently. Like, he would want me to, and I'm like, that, okay, we'll
beautiful.
keep him. Like, amazing. I love that because you're a team. And again, if you were recovering from anything else, we would expect our partners, because that's why we married them, to support us through that recovery process. I wish, again, in terms of what could be removed, is that we could just remove the idea that the quote bounce back happens without the work. A lot of times the work has to be there. And I always clarify because this always comes up. Like, if I take 100 people post ACL repair, there's probably one person in that group who would somehow just recover. Like, right? There's going to be someone in there who would get all of their knee range of motion back, all of their strength, get back to their sports, and do perfectly fine without rehab. But there are 99 who would not. And what we see online seems to be the opposite, is people who are boasting about, look how good I am, look how much progress I've made, look what an athlete I am. And again, my immediate thoughts go to,
About their symptoms, what I always warn women about is she's not telling you how she feels. You don't know how many pads she has on. You have no
correct,
idea what her lower back pain is. Like, I know because I posted about my recovery and I was being honest, but I was still
same.
processing after my first, what was happening to me, and after my second, I was a lot more honest. My first, I was
Mhm.
just like, I look great, come and train.
Mhm.
But I was
Mhm.
devastated. I ran 14 months into it. And so you don't know how
You
honest
don't
and
know.
vulnerable someone is online, because it's a hard place to be honest and vulnerable on. So
Yeah,
like,
trust me.
yeah, you're right, that comparison needs to go. Now, your book, I've been trying to get my hands on it, but I think because I'm in the UAE, it's still challenging, so I will try to get it sent to Europe. But can you tell us a little bit about the work that you've achieved? I'm honestly in awe, and I can't wait to read it. So yeah, tell us a little bit about the book, because some professionals might be listening as well, not just moms.
Yeah, the book too, though, I mean, I looked at it as what would I have wanted to read before I even was in public health. So the big thing with the book for me was that I wanted it to be something that could be read by the general population, no matter who you are. So we have a lot of really great resources now in terms of public health that have come out in the past 5 years, none that are specific to athletes. And so, again, we know that athletes are more likely to experience pelvic floor dysfunction, whether they realize it or not. And I say all the time, my job is pulling people out of the river. Like in the clinic, I am pulling people out of the river who have tried all the things and they end up in my office and we're a last resort. And I'm dragging them out, right before they just say, you know what, whatever, I'll have these symptoms for the rest of my life. I have done that for enough time now that, again, I would love to stop people from just falling in the first place. So if I could go back to my high school self, to my college self when I was playing sports and say, hey, you're experiencing urgency, frequency, occasional hip pain, back pain. If I could have learned about my pelvic floor a little bit then, would I have decreased a lot of my symptoms in pre postnatal? Would I have decreased a lot of my symptoms in my sport? Would I have been able to play my sport for longer periods without pain or without symptoms? And so my question in writing the book was like, what would I have wanted to read, even as someone who doesn't have a background in pelvic health? The challenge is trying to take, like we've said, very nuanced, complex information and put it into something that's very easily digestible. So I have read the book now probably 150 times. I've actually got to go home and have it back by Friday because final edits are this week. Like, this is it. And every time I read it, I stress a little bit. Is this oversimplified? Did I explain this the right way? But it also has to be something that is digestible for the athlete or for the orthopedic PT who's not interested in pelvic health, but just wants to learn enough to know when to refer out. And so it was meant to be something that can be read by anyone, regardless of if you're in pelvic health or not. If you're an athlete, you want to know more about your body. If you work in this space and you want to hear more about how it affects athletic performance specifically. And that's a lot to try and kind of like get into black and white writing. But to me, the challenge is, we can bark all day on socials about, oh, everything's nuanced and it all depends and we can't fit it into a 90-second reel. It doesn't matter. There's no level of nuance that matters to an athlete if they don't ever get to your office in the first place. So if they don't know that they have pelvic floor dysfunction, or they don't know who to speak to about it, or they don't know what even is pelvic floor dysfunction to be able to bring it up in the first place, all my clinical experience and nuance that I want to apply to them will never get to them because they never made it to me. And so the goal of the book was, I don't care who you are. I want you to learn more about your body. I want you to understand it better. I want you to know that there's options for these things that you may have not even realized were problematic. And if we can catch them a lot earlier, teach you how to advocate for yourself, teach you how to step into a doctor's office and ask those questions, and know who to speak to about these things, then we can let those clinicians, providers, trainers, coaches implement all of the nuance that we know so well. If I try to write a book that covers every detail and covers every case and covers every different distinction, I will never be done writing the book. And then no one ever learns. And so I've
And
had
no
to
one
just kind of
read
like
it.
say, you know what? This is what it is. This is where it starts. The discussion starts here. And putting that in the hands of the athlete to allow them to be a better advocate for themselves. In an ideal world, they don't have to do that, right? In an ideal world, we advocate and they
Well,
get
in
better.
an ideal world, the obstetricians are the first to read your book, I would say, because they're
I
the
hope so.
first contact. I find it sometimes very frustrating that don't get me wrong, I think I'm an exceptional Pilates instructor, but it shouldn't come from me. They shouldn't have to, like, I recently had a client who could not defecate without using her hands
Yep.
and who has since had two C-sections. And I have to be the one 6 years after that first forceps delivery telling her, let me teach you a few relaxation exercises and let us do a bit of hip mobility and see if these tissues will just soften and allow things to pass. And in 2 weeks, her life has changed. Why does it have to be me? Like, the doctor shouldn't just say, oh, you were stitched up too tight. Send me to a scar tissue specialist. Send me to a mobility specialist. Why? So I love that you've written this book, because I think it's good. It makes it quite tangible that these professions have something to read,
Yeah.
that is backed enough by all the things we've mentioned, research, evidence, but also logic and clinical expertise, so that it makes sense to the people who will be referring out to you or to me or to whomever. So
Yeah.
well done.
That's the hope.
Congratulations. Well, I
Thank
can't
you.
wait to read it. I want to thank you for your time. I know you have your kids are out of school. How old are they again?
5 and 8. So we're very close to you guys.
Yeah, close to us. So thank you so much for spending the time. And I hope this reaches as many people as possible, as many women as possible, even men who can tell their women, you know what, maybe you've not tried that. Where are you based? If people are
I'm
in.
in Charlotte, North Carolina, so on the East Coast of the United States. I do some telehealth. The laws here are interesting, so it depends on like rehab versus training, but I can be accessible in some ways virtually for people who need it or feel like they are missing something.
Yeah.
So that's an option for some people as well.
Thanks again.
Of course,
Oh,
thank you for having me.
see you soon.